Thank you. Firstly, let me thank the organizers for inviting me to speak today. Now, I might be the youngest person doing HIFU. Many of you all have done HIFU much more than me. But I have been doing IVF for 25 years. I have been doing laparoscopic surgery for 30 years. So I'm going to combine these two and see how HIFU can help, especially my infertility patients, to achieve a better chances of pregnancy. Now, this is my disclosure. I have been doing HIFU in this hospital since 2021. And these are a number of cases that I've done. I started in the middle of the pandemic, in 12th of July 2021. And until about 2 weeks ago, I've done 581 cases, out of which 366 are fibroids and 215 are adenomyosis. So I'm just going to explain how I select patients, especially patients with infertility, when I perform HIFU for them. Now, many people will ask me these two questions. The first question is, how does HIFU affect ovarian function? Thankfully, Vincent have already answered this question, so I've got not much work to do here. Second is, does HIFU affect the endometrium? This is the next question that people will ask me, so I'll try to answer these questions first. Now, the first question, as what Vincent has said, is, now, when we shoot the beam into the fibroid, this is how it goes. The focal point is here. This is where the maximum damage is. But there is still some energy that is involving these areas. So as you know, fibroids are all over the place. When we ablate the center, the ovary will not be affected. But when we ablate the sites, there is a chance that we may affect the ovary. So it's always in our mind whether there is some ovarian function that will be affected. But as what Dr. Vincent has said, there are studies. This is only one study that I showed. I knew that Dr. Vincent has got his study much earlier than this, and they have done studies that show that the AMH level before and after HIFU has not much of a difference. So we can safely say that HIFU most probably will not affect the ovarian function unless you're doing fibroids that are very lateral, very to the left side or to the right side. Okay, the next question is, does HIFU affect the endometrium? Now, when we ablate an anterior fibroid, we are not going through the endometrium. We are going right here and the endometrium is not affected. But when you are ablating the posterior fibroid, like here, posterior fibroid, we are going through the endometrium and hitting the fibroid behind. So it's always a worry whether the energy that is going through here, will it affect the endometrium? It's always in everybody's mind. And this is a study that was done that actually they took endometrial samples from the endometrium of women before and after HIFU, and they found that it did not, and they looked at a lot of factors. I don't want to go through all these factors, things like penipodia and a lot of things, and they found that it does not affect. So we can safely say that the HIFU will not affect the endometrial cavity, but I think we need more research on this to reassure us, especially IVF specialists, that when we shoot a beam through the endometrium to the posterior wall, the endometrium is actually not affected by this energy. Now, the next question I always ask myself is, if you have a fibroid like this, and this is the fibroid, and you ablate, does this ablation at the capsule here near the endometrium, will it affect the endometrium or not? These are submucous fibroid, or maybe type 3 submucous fibroid, even type 2 submucous fibroids. This is another example. For example, this fibroid. This lady has a fibroid right in the center of the uterus. This is right in the center of the huge fibroid. It's about almost 10 centimeter fibroid in the center of the uterus. If we were to ablate this, will the ablation affect the endometrium? I think there's no answer. There's no study to show that if we say we give GnRH analog, shrink it, and do TCRF, are we going as much damage or less damage than if we are doing HIFU for this patient? For this particular patient, This was the ablation that I did, and 3 months later, almost all the fibroids have come out. So it's good for her, but is it good for the endometrium? I think we got no answer to it. We still do this when young girls or women in the single and they don't want anything to go into the uterine cavity, want to do HIFU, and they have a large submucous fibroid, which is very difficult to do TCRF. I always talk about this balance between doing a transcervical resection and doing HIFU, which is cause more damage to the endometrium. And I think we don't have an answer to this question. Okay, next I will just talk a little bit about my experience when patients with fibroids who want to get pregnant come and see me, and how do I choose whether I will do a laparoscopic myomectomy, open myomectomy, or do HIFU. And this is always a debate, which is a better option. Now, in my mind, when we talk about myomectomy versus HIFU in patients with infertility, if the patient comes with recurrent fibroids, say the patient has undergone a myomectomy before and she has another fibroid and she said, can you do HIFU for me? I will not hesitate, I will do HIFU for her. Now, if the patient has multiple fibroids, there's a lot of fibroids, and I know that if I do the surgery for her, within 1 or 2 years she's going to come back with fibroids, then I will not hesitate to do HIFU for her. Single women with fibroids, yes, we don't know when they are going to get married, when they are going to get pregnant, then I will not hesitate to do HIFU for these patients. However, if a patient has got a large fibroid and she's keen to conceive as soon as possible, I usually hesitate to do HIFU. Because if I do HIFU, it's going to take time for the fibroid to shrink, and she's going to come back to me and bug me, I'm not getting pregnant. Is this fibroid going to cause me difficulty in getting pregnant? So these are the group of patients, especially if the patient is about 35 to 40 years of age and she has a large fibroid, then I will tell her that I can do HIFU for you, but maybe surgery is better for you, because if I do surgery, after 3 months, 6 months, she can get pregnant. But there are enough studies to say that even if you do HIFU and the fibroid shrinks, they can conceive on their own. But I am always on the what I call as on the safer side, where I say that maybe myomectomy is better for you, but if they insist, then I'll do HIFU for you. So this is always a debate when you are an infertility specialist, which is better, to do myomectomy or to do HIFU. And I have got both the facilities. I'm not a person who only do HIFU. I can do a lot of things, so I can tell them that these are the options. You decide. Sometimes they ask me, what is your option? Then I use this as a guideline, as a way to decide which patient is better to do HIFU and which patient is better to do myomectomy. Now, there's another group of patients that I always have difficulty. These are the group of patients who have small fibroids, say 2-3 centimeters fibroid or 3 to 4 centimeter fibroids, and they're not getting pregnant. This is a review paper that I wrote some years ago, intramural fibroid and fertility, to operate or not. That's by me. And in here, I studied all the different methods available. These are patients with, say, type 3 fibroid or even type 4 fibroids. These are fibroids sitting in the myometrium, not touching the junctional zone, not touching the endometrium, but they are not getting pregnant. What are we going to do with them? Are we going to operate on them to take out this small 4 centimeter, 3 centimeter fibroid? Can we look for another option? And these are the groups of patients I think HIFU will be a good choice. And I actually give you an example of a patient that I did this, and the patient conceived. So this is another group of patients that may be a good candidate. Instead of opening them up and taking out the fibroid, may be a good case to consider HIFU. This is an example I give you. This lady has this small fibroid. She was not getting pregnant. The fibroid is not big. There are 2 small fibroids. I could easily do laparoscopic myomectomy for her. This is how it looked on this one. It's a small, one fibroid here and one fibroid here. It was touching just about touching the junctional zone. And this is the contrast MRI. And you can see that here, you can see the fibroid there, this fibroid and this fibroid, 2 fibroids. And this is the contrast MRI. This is after I've done HIFU. HIFU was okay, not very difficult, simple case. And this is 3 months later, the fibroid became smaller. And she conceived and she got pregnant. But I also was worried, if she doesn't get pregnant, then we may have to go and do a surgery. So these are a group of patients that we can consider HIFU as an option. as opposed to doing surgery for these kind of patients. Okay, next we go, this is the patient. What happened is after 3 months, the fibroid shrank, and this is the first fibroid, the big fibroid shrank by 49%. The second fibroid shrank by 58%. And I do 3D ultrasound to measure the fibroids. And as I said, this patient actually conceived and she delivered normally. Okay, next we come to the awful subject of adenomyosis. This is a much more difficult topic, and this is my favorite topic. Now, as what Hugo was asking us just now, fibroids are easy. They have got a capsule, and you can ablate, and you can even ablate 100%. It's not a problem. But adenomyosis is a different ballgame. They are all over the place. It is impossible to do 100%. It is everywhere. It's right up to the serosa, it's right up to the endometrium. And it's even more difficult when you're doing for patients who want to get pregnant, because you need a barrier of about 1 to 1.5 centimeter from the endometrium. And here you need a margin as well. So you have to be much more careful when you're doing HIFU for adenomyosis as opposed to fibroids. And recurrence rate is 100%. I'll tell you it's 100% because I have not ablated this part. I have not ablated this part. It's going to come back if you don't do anything. So I always tell my patient, if they ask me, what is my chances of it coming back? I tell them it's 100%. I'm just helping you to reduce the volume of your adenomyosis. And if you take a GnRH and if you put in a Mirena, there's a good chance that we can delay it for 5, maybe 6 years. That's how it works for adenomyosis. But for a person who is going to want to get pregnant, my ablation has to be even more careful. That means I have to ablate even lesser than a patient who doesn't want to get pregnant. So if you don't want to get pregnant, I will do a more aggressive ablation, and more disease will die, and your chances of recurrence will be lesser, as opposed to a person who wants to get pregnant. Okay. So as I said here, there is a difference in ablation in a person who don't want to get pregnant, because I can do extensive ablation and I can even include the endometrial cavity, and the success rate of reducing symptoms will be good. As opposed to a patient who wants to conceive, I have to be very careful not to involve the endometrium. And as what Dr. Ising Lee has said, some of the adenomyosis actually reach the endometrium. It's impossible sometimes to control the energy not to involve the endometrium. And sometimes I wonder whether if the endometrium is already involved, ablate it and let it die and let new endometrium form. That may be a concept, but I don't think Chongqing agrees with me on that. So you see, when we see patients with adenomyosis, these are the group of patients that I see. Those who are not keen to get pregnant, very easy. I can do fantastic ablation. Those who are keen to get pregnant, then we have 3 groups of patients. Those who have frozen embryo, those who are still single, and those who want to get pregnant spontaneously. And this is the group that I don't like. These are the 40-year-old single ladies who are not sure whether they want to get pregnant. I don't know whether to do a complete ablation or a careful ablation. Today I will talk about pregnancy. I like this group, those who have frozen embryos. Now, if a patient has got a frozen embryo, these are patients actually who have done IVF, who have failed embryo transfer, 1, maybe twice. And then they are saying to me, can you do something about this and the adenomyosis? Please kill the adenomyosis, make it smaller for me so that the patient can get pregnant. I love these patients because if I succeed, I'm a hero. If I don't succeed, I say you have terrible adenomyosis. So I have got no problems with this. So I like this group of patients. So I have to do the ablation very carefully to prevent the involvement of the endometrium. I usually give them a GnRH analog for 3 months. And then I will refer the patient back to whoever the patient is doing IVF, and I'll ask them to do the embryo transfer. And I ask them to do the embryo transfer before their menses comes. That means while the uterus is at the smallest size. In my experience, the uterus becomes the smallest about 3 months after the GnRH. And usually GnRH lasts more than 3 months. The ones I give are the depot, which are 3 months one. Usually lasts 4, 5, 6 months. So at 3 months, the uterus is the smallest. That's the best time to do the embryo transfer. I'll give you an example. This is a lady. She's 35-year-old, married for 5 years with no children. In 2019, she underwent IVF, had 2 frozen embryos. One embryo was transferred in June 21. She did not conceive. Then her uterus was about 16 gestational week size. Ultrasound showed a large posterior adenomyosis, 9 by 10 by 8 centimeters. And this is how adenomyosis looked. It was a large right-sided adenomyosis. It was almost involving the endometrium. This is how big it is. And this is the power setting I did, 146 seconds, 1335. And these are the power setting. I think those who are doing HIFU will know what this is all about. So this is how the adenomyosis looked like. And this is the MRI done 3 months later. So we had almost a complete, I didn't do immediately, but I did 3 months later. This is how the adenomyosis looked like. And this was the volume changes by ultrasound after HIFU. So at the beginning, it was 946.92 centimeter cube. For those who don't know, the normal size of a uterus is about 60 to 80 centimeter cube. So this was almost 10 times the size. And at about for 6 months, I think it's about 6 months, it was 265. This was my first case, so I waited. And I sent her back to her IVF specialist, and she did the frozen embryo transfer. She did not induce bleeding, and she gave, those who do IVF will know that we will give Proganova for, this is estradiol valerate, for 11 days, and then added utrogestin, and then she did a frozen embryo transfer on the 25th of June 2022, and recently she delivered by cesarean section. This is a photo. She allowed me to show this photo. So far in my series, this is my series, we have 8 adenomyosis patients, 5 have delivered, 4 by cesarean section, but unfortunately 1 patient died. The baby died at 28 weeks, and she delivered by SBD. 2 miscarriages, and 1 is ongoing. In my fibroid list, 7, 6 delivered, 5 LSCS, 1 SVD, and 1 is ongoing. This ongoing patient is actually a patient with multiple fibroids, and HIFU was done. She couldn't get pregnant. We did IVF, did embryo transfer, and she's now 16 weeks pregnant. So in summary, offering IVF, HIFU for patients with fibroid must be done very carefully. I think when we do patients who want to get pregnant, if you want to do HIFU, you have to discuss very carefully, because we have a good alternative, that is surgery. For those who don't want to get pregnant, I think it doesn't matter. HIFU is probably the best choice. But those who want to get pregnant, we have to be very careful. And you must discuss the pros and cons of HIFU versus myomectomy. Let the patient decide which one they prefer. Each has its own advantages and disadvantages. As for adenomyosis, HIFU is probably superior to adenomyomectomy in patients who want to conceive. That's what I think. I've reviewed the articles. The studies have showed that those who do adenomyomectomy, some have even quoted up to 50 to 60% pregnancy rates, but those are done by people very good, like Osada, who are very good at adenomyomectomy. So they get, and their uterine rupture rate is very low. But those who are not doing, we are always worried about uterine rupture. Not all adenomyosis cases are the same. In some adenomyosis cases, the ablation is easy. In others, it's very difficult. In women with adenomyosis who have difficulty in conceiving, especially after failed IVF, HIFU is an option to shrink the adenomyosis before embryo transfer. There are many challenges in performing HIFU for these patients, including how much to ablate, how to avoid endometrium. This is always my fear, because those who do HIFU will know that we cannot see very well the ablated areas. Sometimes we can see the grayscale very clearly, sometimes we can't, and when we do MRI, the ablation is actually gone to the endometrium, so it's sometimes very difficult. The next difficulty is to decide when is the best time to do frozen embryo transfer. My suggestion is at 3 months post-HIFU. I also use the CA125 to decide when to do the HIFU. So I usually do a CA125 before HIFU, and then follow them up. When I follow them up, I'll check the CA125. It did not become normal. I'll give the generation until it becomes normal. Then we do a frozen embryo transfer. Now, HIFU can also be done in patients with adenomyosis who want to conceive spontaneously, but she must be prepared to repeat the HIFU treatment if she did not conceive and the adenomyosis recurred. I have not had the experience of a patient whom I did HIFU and the patient conceived spontaneously, but I recently reviewed the literature in China. There are a lot of patients who conceive spontaneously, but I have not been that successful. And in these kind of patients, I always tell them that if you don't get pregnant either, you choose IVF as soon as possible, or you may have to come back for a second HIFU in 1 or 2 years' time if you don't get, because it's going to grow back. And here we have to consider IVF early in these patients. Okay, thank you.